Hi, I'm Dr. DJ Heusler, and this is our module on anatomy and physiology of the eye. So the eyelids consist of modified skin, which is an epidermis and dermis. This is haired in most domestic species. There's a muscular layer, which is the orbicularis oculi, and this helps to close the eyelid. There's a levator palpebra superioris, and this helps to open the eyelid. There's a tarsal layer, which is meibomian glands, and these are modified sebaceous glands. Glands of Moll, which are modified sweat glands. There's a tarsal plate, and then there's conjunctiva, which is composed of vessels, nerves, and lymphatics. So here are two photos, one of a gross specimen of an eyelid, and then the second photo is a histologic picture of an eyelid as well. The eyelid's main function is to protect the globe. It has a palpebral reflex. It removes surface debris from the corneal surface. It contributes to tear film with the meibomian glands as there's a lipid layer. And then blinking helps to distribute the tear film across the cornea. It regulates light entering the globe via squinting. As we talk about the cornea, we'll be talking about the epithelium, the stroma, Descemet's membrane, and the endothelium. And it's important to remember that the cornea is only about 0.5 to 0.6 millimeters thick. The cornea supports the internal contents of the eye. It refracts light and helps to transmit light. The aqueous humor and the tears supply its nourishment. It is an avascular structure in domestic species, and it's typically less than 1 millimeter thick. The anterior epithelium is about 20 to 40 micrometers thick. It's composed of 2 to 3 layers of non-keratinized stratified squamous epithelium. The stroma is about 90% of the thickness of the cornea. The stroma consists of keratocytes, which possess crystallins, which are believed to facilitate transparency. And these can transform into myofibroblasts during deep corneal injury. This forms scar tissue and loses transparency of the cornea. The stroma consists of collagen fibrils, which are broad belts called lamellae that run parallel to the corneal surface. The stroma also contains nerves and glycosaminoglycans such as keratin sulfate, chondroitin sulfate, and dermatin sulfate. Innervation is provided by branches of the trigeminal nerve, which enter the midstromal region circumferentially around the limbus. They course radially to the central cornea in the stroma, and there are free nerve endings that extend up to the epithelium. In regards to innervation, brachycephalics have less nerve fiber density than mesocephalics, and dolichocephalics are more sensitive, more painful, and this may be a contributing factor for less ulcer development in dolichocephalics. They have more of a pain response. They're more apt to protect their eye as compared to brachycephalics that can't necessarily feel their eye as easily. Diabetics also have reduced corneal sensitivity. The endothelium is a single layer of flattened cells, and it's possibly regenerative in younger animals, but it's non-regenerative in older animals. The endothelium has a density of about 3,600 cells per square millimeter in dogs less than 1 year old. And as the animal ages, they will lose greater than 50% of these cells. Other cells become pleomorphic at this time, and it's typically less than 2,100 cells per square millimeter in older dogs. The endothelium has sodium-potassium ATPase pumps, which actively pump fluid out of the cornea to keep the cornea relatively dehydrated at about 75 to 85% water. The endothelium regulates hydration of the corneal stromal collagen, which provides mechanical strength to the cornea. The peripheral cornea is thicker than the central cornea, and there's a decrease in corneal thickness until approximately 6 weeks of age, and then it increases until the dog is 30 weeks of age. The function of the uvea is to provide nourishment, as it's the main intraocular vascular supply. It brings oxygen to the highly metabolic retina. It produces aqueous humor in the form of a clear ultrafiltrate. It regulates light via its pupillary aperture, and it provides accommodation. Pathophysiology of uveitis includes tissue injury to the uveal tract, increased blood flow, inflammatory cell infiltrate with lymphoplasmacytic, suppurative, and granulomatous, vascular permeability with breakdown of the blood aqueous barrier, cytokine and prostaglandin release and activation, followed by plasmoid and fibrinoid aqueous, and lastly, pre-iridal fibrovascular membrane formation, or what's also known as epiphyme. As we move on to anatomy of the lens, we're going to be talking about the anterior epithelium, the posterior epithelium, the nucleus, the cortex, and the equator. When cataracts occur, there have been gross and irreversible alterations in lens metabolism related to protein content of the lens, metabolic pumps, ionic concentrations, and antioxidant activity. Cataracts are associated with increased in high molecular weight, insoluble proteins, decrease in relative amount of soluble proteins, and decreased activity of the lens epithelial sodium-potassium ATPase pumps. As we move on to the vitreous comprises 80% of the volume of the canine globe. It's located posterior to the lens and anterior to the retina. It provides pressure to the neuroretina to position the retina against the pigmented epithelium. It's composed of hyaluronic acid and collagen. There's a diffusion barrier between the anterior and the posterior segment of the eye, and the vitreous acts as a metabolic buffer. The stability of the colloid decreases with age, leads to liquefaction of the hydrogel. Fine, white, fibrous structures may become visible in the vitreous. Other degenerative diseases are syneresis, which is degenerative breakdown resulting in liquefaction, vitreal floaters, which rarely result in clinical changes, asteroid hyalosis, which can result from age, diabetes, progressive retinal atrophy, and it typically does not result in vision loss unless it's severe. Intravitreal membranes can occur, which are associated with intravitreal hemorrhage, also associated with epiretinal membranes, retinal neovascularization, and pre-irital fibrovascular membranes, which lead to glaucoma. As we move on to the fundus consists of tapetum, the non-tapetum, the optic nerve, and the retina. The canine and the feline eye are incredibly difficult to evaluate due to the number of normal variants. You can have orange tapetum, yellow tapetum, green tapetums, blue tapetums, non-tapetums, which are red and you're looking directly at the choroid. There's a wide variety of variation, which makes this very difficult to evaluate. And as we look at these photos, these are all forms of normal variants. So the more you look at and the more you practice looking at the fundus in small animals, the better off you're going to be. The feline fundus has much less variation than the canine fundus. The optic nerve head is poorly myelinated, there is a much broader tapetum, and the non-tapetum can be pigmented or poorly pigmented. The canine non-tapetum also has different forms of normal variants. The variations are not as wide as the canine tapetum, but there still are quite a few variations. The canine optic nerve also has a wide variety of normal variants. Optic nerves can vary in location, size, degree of myelination, and shape. They can be triangular, they can be circular, they can be located well within the tapetum or well within the non-tapetal area. They can straddle the non-tapetal-tapetal junction. And to be more comfortable working with all of these variants involves you as the clinician evaluating as many patients as you possibly can. That concludes the Anatomy and Physiology module. Please enjoy the rest of the program.